This week, we're going to be looking into the problem of malnutrition. I'll remind students as well that there are questions at the end of the chapter which I invite you to complete in order to better integrate the information. While nutritional deficiencies in Western industrial societies in general and in the U.S. population specifically have not been prevalent or widespread, they have been a problem in hospitalized patients since about the mid-1970s. The concern about malnutrition within the clinical setting stems from observations of the 1930s by Hiram Strudley, who reported a tenfold hike in mortality rates among patients with peptic ulcers who had lost in excess of 20% of their usual weight. So in this particular lecture, I'm going to cover malnutrition from a broad perspective. First, the focus will be on hospital malnutrition and how we treat it. Then I'm going to be looking at prevalence of malnutrition in the U.S. population, looking specifically at the history of malnutrition. Then a specific focus on undernutrition in developing countries. At the end of the chapter, there's a set of questions that will help students better integrate the information. Currently, if we think about malnutrition, we are probably quick to conclude that it's certainly not visible in our streets, highways, and byways. But malnutrition is indeed quite prominent still in our hospitals. In 1930, Strudley observed a tenfold increase in mortality in patients who had peptic ulcers and who had lost 20% of their body weight. 1970s, Bruce Bristrian documented a 44% prevalence of malnutrition among the general medicine patients. In the 21st century, between 20 to 50% of hospitalized patients are still actually considered malnourished in the U.S., while the prevalence of worldwide malnutrition varies between 13 to 69%. Overnutrition, by contrast, is on the rise in developing countries and developed countries, and epidemiologists have certainly identified key micronutrients that are certainly underconsumed. I'd like to now cover the metabolic concepts that are associated with malnutrition. So let's start with the concept of starvation. In starvation, there's a shift from relying on exogenous sources of energy, or sources of energy that come from the outside, like our food, to endogenous sources, such as our glycogen reserves, our fat reserves, our protein reserves. So what we have to understand here is that weight loss occurs certainly in energy deprivation. However, the rate of weight loss is not proportional to the energy deprivation. It doesn't follow a linear curve. So let's look at the different stages of metabolism during starvation. For example, the first 12 to 24 hours, we're seeing primarily glycogenolysis taking place in this early stages of a fast. That's a breakdown of glycogen primarily from the liver. Around 22 hours, gluconeogenesis is kicking in, producing roughly about 64% of the glucose in circulation in the blood. By this time, we could say that the glycogen reserves at the 22nd hour is very, very limited, and so consequently the body's got to rely on amino acid breakdown, the breakdown of lactate, and other intermediates that lead, that have the sort of gluconeogenic attributes. About 3.5 days, the brain is starting to rely roughly about 25% of its energy on ketones or ketone bodies. Days 4 to 7, 30 to 40% of the body's needs for energy is coming from ketones. And by week 2, it's starting to rely more and more on the fatty acids and on the derivatives of ketones also that are being broken down. But at this stage, we're looking at the body now using proportionally more of the fat specifically, remembering here that ketones are improperly metabolized fat. Then death occurs when roughly about 25% of the body weight has been lost, or when there's a 70 to 90% loss of adipose tissue. There is a better and more detailed description of these different steps in your textbook, so I invite you to go in and read that. It'll give you a more seamless description of the different phases. So let's step back a little bit and get a more broad understanding of what's happening in the catabolic state. So in the catabolic state, there's a shift from exogenous to endogenous reliance on substrate. So the catabolic state usually happens, for example, in cases of starvation. It could be simple starvation, or it can also be disease-generated starvation that leads to a state of stress. We see glycogen being broken down. That's glycogenolysis. We see protein being broken down. That's proteolysis. And we see fat being broken down, lipolysis. Now I want to explore the initial principles of malnutrition that created a little bit of a paradox. 1912 experiment. There were men fed only distilled water for 31 days. And these were the observations: a non-linear weight loss over a 31-day period. Of course, the expectation was that if you have a caloric deficit, you could predict in linear fashion what the person's weight would be after a certain period of time, but that's not what was happening. They recorded a 16.7% weight loss and also reported a 30% drop in bodily heat production. So you can see here that the percent drop in heat production, or in metabolism, for example, was far greater than the actual weight loss. So there was a discordance here. That's the 1912 experiment. By 1940, Ansel Keys out of the University of Minnesota did some interesting research here with young male Army recruits. They were put on 1,600 calorie a day diet over 6 months. That was very prolonged. It produced a 24% weight loss, but also a 39% drop in basal metabolic rate. So again, this discordance that was originally found in the Benedict 1912 experiment, that got reproduced here. What Ansel Keys was able to demonstrate, though, was that after 6 months, the BMR stabilized and remained constant, low, at a low state after 6 months. Well, I want to examine the metabolic state in malnutrition and looking at different endocrine and organ involvement. Around 12 to 24 hours postprandially, that's after you've eaten, the pancreas is affected in malnutrition. There's a decrease in the beta cells of insulin synthesis. So when you're 12 to 24 hours after having eaten, insulin production goes down, and there's an increase in the alpha cells of the pancreas in the production of glucagon. And the glucagon signals basically the body to start producing sugar, notably by exciting the glycogen phosphorylase A enzyme, which is really the enzyme that causes the breakdown of glycogen and thus the production of sugar. So this is one way it can do it. The adrenal glands are also affected. It increases the production of catecholamines and the production of, thus, epinephrine, and this causes sugar to be released as well. Now, the liver is affected. Again, like I mentioned, there's increased glycogenolysis here, so 48 to 72 hours of fasting will produce about 100% of the sugar coming from hepatic glycogen. And then glucose, consequently, from the breakdown of glycogen, is produced to maintain a stable blood glucose concentration. There is, however, after about 22 hours, increased gluconeogenesis, which also contributes at this stage to the production of glucose. By this time, there is less glycogen in the liver, so it actually starts the production of glucose from glycogenolysis, and the liver begins to decline, and the glucose production through gluconeogenesis begins to slowly take over. By the 40th hour, 80% of the glucose is then at this point produced by gluconeogenesis. Glucose absorption also declines. Subsequently, hepatic glucose production falls 40 to 50% right, by the 40th hour. So this is why gluconeogenesis needs to significantly pick up. And again, gluconeogenesis, I'll remind you, is the production or the synthesis of glucose from non-carbohydrate sources in the body, notably protein or amino acids. There is, after 4 to 7 days of fasting, 30 to 40% of the energy needs are coming from ketone bodies, which again, previously I reminded you, are incompletely metabolized fats. And then after about 2 weeks, the body is relying still on gluconeogenesis, but it has shifted more of its energy reliance on that of fatty acids. So now that we've understood a little bit the paradox of malnutrition, let's see who is nutritionally at risk. When we assess patients, we generally look to see if the weight loss was greater than 10% in a 6-month period, and we call this involuntary weight loss. So not people who are trying to lose weight for obesity, but really individuals who lose weight despite not wanting it. And so a greater than 10% really puts an individual at high risk. Weight loss of greater than 5% in 1 month is also pretty high risk. And when the body weight is about 80% of a patient's healthy weight, or even 120% of a patient's healthy weight, we generally say this person is nutritionally at risk. For 80%, it's in terms of undernutrition, and also at 120%, that's in terms of excessive weight gain. So these are sort of medical standards that we go by in disease states. Recent disease, traumas, or surgeries put people at nutritional risk. Whenever there's chronic disease of various types, we talk about the risk of nutritional risks. And food intakes that are very poor over a 7-day period implies some level of nutritional risk. And then when patients are mechanically prevented from eating or swallowing, that also sets off alarms that the person may be at some nutritional risk. Now, additionally, in a state of malnutrition, there's a downward adjustment of our EE. And it goes in segments. In the first 2 weeks, there's a 15% decline. And then afterwards, 3 to 4 weeks later, there's a 25 to 35% decline with respect to the baseline resting energy expenditure. Well, I want to examine the causes of this malnutrition. First, there is the malnutrition that occurs before being hospitalized. This is the result of chronic disease or malignancies. There could be psychological disorders that, influence the desire to eat or the desire not to eat. Elderly, prone to financial difficulties and becoming functionally compromised, thereby making it more difficult for them to leave the house and go and get groceries, for instance. There's also deterioration of nutritional status while in hospital, resulting from the difficulty of swallowing, degenerative neurological disorders that compromise eating, trauma, ventilator-dependent patients have increased energy requirements during that difficult period of time, and there are difficulties in initiating, if you will, nutritional support. So consequently, waiting for delayed nutritional support implementation can also lead patients to a compromised nutritional status. So now I want to turn your attention towards the assessment methods for hospital malnutrition. Before considering the different methods of assessment of malnutrition, let's consider the 3 distinct origins of malnutrition in a hospital setting. Starvation-related malnutrition is certainly the first one to consider. Malnutrition arising from chronic disease or mild to moderate inflammation. And then malnutrition from acute disease or injury, accompanied by severe inflammation. So there's one particular standard assessment method in which among the A, B, C, D, E's, at least if one of these criteria are met, the patient would be at nutritional risk. Let's see. If A, weight loss or weight gain is greater than 10% of the usual over 6 months. If weight loss or weight gain is greater than 5% of the usual within 1 month, and this is of course involuntary weight gain or weight loss, and then body weight that is either 80% or 120% of the healthy weight is indicative of nutritional risk. Has chronic disease or change in metabolic needs. Changes in metabolic needs could be tied to, for instance, increased trauma or stress or inflammation in the body due to disease processes, and this of course increases the resting energy expenditure. Chronic disease, for example, also does the same thing. Hasn't eaten adequately any food or supplement for more than 7 days puts the patient at risk, and a patient with difficulty swallowing or absorbing food for more than 7 days. So when you're assessing a patient, if any one of these criteria emerge in your assessment, then automatically the patient is at nutritional risk. There is also a rapid way of assessing a patient, and it's basically in 3 steps. First of all, assessing whether or not the weight loss occurred or did not occur without trying. If there was no weight loss, 0 points, and if you're not sure, 2 points. How much weight loss? 1 to 5 kilos, 1 point. 6 to 10 kilos, 2 points, and so forth. And then, is there poor appetite? Yes, that's worth 1 point. And if there's no loss of appetite or poor appetite, that's 0. So the interpretation then is a value greater or equal to 2 means the patient is at risk of nutritional support, thereby warranting full nutritional assessment by a dietitian. So as an example, if a patient presents with, let's say, 4 kilograms of unwanted weight loss, that would be 1 point. And when asked whether or not they had poor appetite, they said yes, that would warrant a 2nd point, and that in itself would be 2 points and would require then a referral to a dietitian. Another popular assessment tool is called the Malnutrition Universal Screening Tool, or MUST. And this screening tool is based on 3 criteria: the BMI, the percent body weight loss, and the food intake. So when we're looking at the BMI, a BMI that's greater than 20 represents no risk, score of 0. A BMI of 18.5 to 20, slightly underweight, represents a medium risk, score of 1. A BMI less than 18.5 is a serious risk, and that's a score of 2. Now, the other criteria is percent body weight loss. So less than 5% body weight loss in a 3 to 6 month period. And if, again, this is unwanted body weight loss, that represents no risk, so a score of 0. 5 to 10 within that period is moderate, score of 1. And greater than 10, 3 to 6 month period, is also scored as 3, sort of high risk. Now, with respect to food intake, if there's no food intake, there's risk of no food intake also during that higher period of greater than 5 days, then we're looking at a score of 2. So when we do the risk assessment, a score of 0 equals low risk, a moderate risk is 2 to 4, and a high risk is 5 to 7. This kind of assessment can be completed by a nurse, and of course if the assessment results indicate moderate risk or high risk, then a needs assessment would have to be implemented by a clinical dietitian. From this needs assessment, the dietitian then could make recommendations for a particular nutritional support to assist in patient rehabilitation. In very sick patients, sometimes the height is very difficult to acquire and to make an accurate measure. So there are specific protocols, such as using simply the body weight. And for standard care, usually 25 calories per kilogram body weight is sufficient calories and accurate enough as an assessment to essentially keep patients alive and supporting them in their recovery. To give you an idea of how burn patients, for example, is a form of trauma, is significant and how it really increases the energy needs of the patient, the prescribed amount of calories in this context is 40 to 45 calories per kilogram body weight. So a substantive increase in the caloric delivery per unit of body weight. So then, when faced with a case where only the body weight is given and the height is not given, or the body mass index, then you have this protocol, the standard protocol of 25 calories per kilogram body weight that can be given in this context. On the other hand, if you do have the body weight, the age, and the height, you can use the Harris-Benedict equation, which is nicely described in Table 8.2 in your textbook, and it's an appropriate equation for women and men that are sick and hospitalized. The Mifflin equation and the Garrier equation, by contrast, is used exclusively in individuals who are healthy and living in an active life outside the hospital or outside of specific bed care. This is a good equation to memorize, just like the Mifflin equation. Very similar in numbers and in basically format of equation, but at the very least have a cheat sheet of this equation. The total energy determination is done using activity factor and injury factor. Now, oftentimes when we refer to a patient as hospitalized, it really does mean that they are confined to the bed, so usually 1.2. If they are at home but sick, and so basically being cared for at home, it is possible that they are out of bed. In that way, you can use that particular kind of equation, but it's still a hospital-like, sickly individual, right? Hospital care-like, even though it's given at home. The injury factor, surgery, 1 to 1.2, infections 1 to 1.8. That varies. It is subjective. Skeletal trauma 1.2 to 1.35. Multiple traumas and the use of steroids, you're much higher, 1.6. And of course, blunt trauma 1.15 to 1.35. So these are indeed good guidelines to work with. Oftentimes in specific types of problems, I'll give you the injury factor, but do remember to also include on your own the actual activity factor. Here's a specific case that you can work on. A 33-year-old patient weighing 179 pounds, has a pre-illness weight of 165 pounds with multiple fractures. His height is 5 feet 11 inches. So what are we going to do? First, his REE is determined using the Harris-Benedict equation. It's clear that this patient is hospitalized. So here's the equation, and I've entered the specific numbers related to either the weight, the height, and the age. And then notice how specifically the numbers inside the parentheses are done first. So the first parentheses, 13.75 times 74.91, gives us 1030, and then the second one, 1.85 times the height in centimeters, 180.34 centimeters, gives us 336.63. Notice how that gets added then to 66.47, and then all of that number totaled together minus 223, which is the 6.7 times or 6.76 times the age, will give us an REE of 1207. Now we enter the activity factor and we enter the injury factor. So this is a multiple trauma, so it's clear that we're going to use 1.6, and of course the patient's confined to bed, so the activity factor is 1.2. When we look at protein, we can also sort of gauge what kind of a requirement this would be based on. I really encourage students to read the chapter. Effectively, it refers to fractures and infections, as well as multiple fractures as a particular protocol. And we would be using probably somewhere around 2 grams per kilogram body weight, because it's multiple fractures, times the body weight of 74.91, and that would give us our requirement for protein. Now, if we complete the calculation, 2 grams per kilogram body weight times 74.91, we get 149.82. And we want to know what percent of the calories this represents. So we multiply that by 4 calories per gram. That's 599 calories. So to get the percent, 599 divided by the total number of calories assigned to this patient, 2,317, times 100, we see that protein prescribed at 2 grams per kilogram body weight actually equals 25.86. If I decide to, as the dietitian, to prescribe 25% of the calories as fat, then I can basically derive the carbohydrates by subtraction. 100 minus the addition of 25.86, which I derived for my protein, and 25% for my fat, and that leaves me with carbohydrates at 49.14%. So this is actually my full prescription. Now, once the energy requirements of the patient have been established using the activity factor and injury factor, now in the next step, it's probably acceptable to establish a prognosis for the patient. And of course, using the prognostic nutritional index is good. A reminder here that a prognosis is really an estimation of how well the patient will do in the future. So in other words, what you're really measuring is the risk of morbidity. So if the patient has a high nutritional index, or a PNI, prognostic nutritional index, then he is at high risk of morbidity or of becoming profoundly ill. So what I've done here is I've entered the values of 2.2 grams per deciliter for albumin, 5 millimeter measurement for the tricep skin fold, 150 milligrams per deciliter for the transferrin, and for the delayed hypersensitivity, essentially a 1 millimeter ring. So as we calculate this, notice how I do all the calculations in the parentheses first, and then as we do that, 16.5 times 2.2, I get 36.3, 0.78 times 5, I get 39, 0.2 times 150, I get 30, and then 1 times 5.8, I get 5.8. So the 159 then subtracts the addition of all these values, and I get 47.9, sorry. So then, because it's between 40 and 49, it's an intermediary risk of morbidity. Now, this is a cheat sheet that I recommend for students that you could basically print from your downloadable PowerPoints. But this is a good one to sort of remember, and it's got the activity factors and it's got the injury factors that you could work with in order to establish the total energy needs of a patient. Once energy requirements are estimated, looking specifically at injury factor and activity factor, the next macronutrient to estimate is proteins. Elective surgery has a recommendation of about 1.1 gram per kilogram body weight. This is not significantly higher than the physiological requirement of 0.8 grams per kilogram body weight recommended for healthy individuals. Also of note that when health eating guidelines make macronutrient recommendations of protein of 10 to 35% of DRI calories, note that the 10% roughly estimates the 0.8 grams per kilogram body weight, and 35% is roughly around 1.5 grams per kilogram body weight. So elective surgery does not significantly increase protein needs, but fractures and infections do. Note 1.5 all the way up to 2 grams per kilogram body weight. Multiple fractures, in addition to burns, will have a great deal of variability here. So indeed, a physician's and a dietitian's subjective assessment of the situation is very important, but generally speaking, the recommendations vary between 2 and 4 grams per kilogram body weight. Now, while there's a lot of I guess, dispute and controversy around these higher levels of protein, the U.S. Has taken a consensus in critical illness when it comes to protein. And generally, it is understood that when the intake is 1.5 gram per kilogram pre-illness body weight or less, there tends to be a positive recovery from that level of protein. So while some may venture into 2 and 4 grams per kilogram body weight, what appears to be a pretty solid recommendation is the 1.5 or all the way up to the 1.5 gram per kilogram pre-illness body weight. So please take note of this. Now I want to draw you into a broader understanding of protein needs. The basis of protein needs is based on the concept first of nitrogen balance, the amount of nitrogen consumed versus the nitrogen that's actually excreted. And this is important in protein because nitrogen is one of the key components of amino acids. They form the amino group. So this is what makes protein metabolism very unique. The second component I want to review is biological value, and I want to examine the digestibility of the protein itself, which also imparts a certain aspect of quality. In other words, the more difficult to digest, the less protein absorbed. And then again, the easier the digestibility, the greater the amount of protein absorbed, so long as we're talking about quality protein. Now, I want to pause here to provide some insight as to where this understanding of protein requirements come from. And it's singularly an interesting discussion because protein is really metabolized in a much different way than carbohydrates or fats because of the nitrogen component of the amino group of the amino acids that make up the protein. And so what I want to explain here is the concept of a nitrogen balance of the nitrogen taken in exogenously through food and the nitrogen that is excreted via all of the nitrogen routes, the skin, for example, in the GI tract, and also through urea nitrogen. So understanding nitrogen balance fundamentally begins with the understanding of nitrogen in versus nitrogen out. So nitrogen in is what is brought in exogenously from external sources, and the nitrogen out is what is excreted from the body. So when we look at the calculation then, nitrogen balance or N balance is equal to protein intake in grams divided by 6.25 minus the larger parentheses, urea nitrogen plus nitrogen in the stool plus nitrogen in the skin divided by 0.85. So if we follow this particular problem of 135 grams of protein consumed, of a net nitrogen urea of 6 grams and a net stool of 3 grams and a net skin nitrogen excretion of 1.2 grams, we can determine whether or not the individual is in positive nitrogen balance or in negative nitrogen balance. In wanting to explain in the nitrogen equation, the nitrogen balance equation, why grams of protein are divided by 6.25, I want to make two major assumptions. The first assumption is 95% of all body nitrogen is derived from protein. The second one, which is really critical in understanding 6.25, is that 16% of protein consists of nitrogen. So now in the calculation, I want to focus on assumption 2, that is 16% of protein consists of nitrogen. So if that's the case, then we can posit the following equation. 0.16 times grams of protein equal grams of nitrogen. Or, in other words, we could also say grams of protein equal grams of nitrogen divided by 0.16. Or in other words, grams of protein equal grams of nitrogen times 6.25. So where did the 6.25 come from? Well, actually, it's the equivalent of 1 divided by 0.16. So illustrated here, the grams of nitrogen times 1.1 over 0.16 is indeed equal to grams of nitrogen times 6.25. So here we get the origin of 6.25. It's 1 over 0.16, and you can see the rationale of this calculation, how it can be used here in the example of finding grams of protein, but in the next slide I'll show you in terms of discovering grams of nitrogen. So I'm going to draw your attention towards the equation at the bottom, and then I'm going to reproduce it here on the slide. Grams of nitrogen times 6.25 equal grams of protein. So now in this slide, if a particular patient consumes 130 grams of protein, then you should, from this particular given amount of protein, determine the grams of nitrogen. So here I reproduce the equation from the previous slide. Grams of nitrogen times 6.25 equal grams of protein. So therefore, algebraically, I can now determine grams of nitrogen based on protein intake. So grams of nitrogen equal gram of protein divided by 6.25. And this is exactly what we were getting in the nitrogen balance equation, if you remember from a few slides ago. The next aspect of the nitrogen balance equation is trying to explain why urea nitrogen is actually divided by 0.85. And so the main assumption here is that 85% of total urinary nitrogen is in the form of urea nitrogen. Now let's look at a concrete problem. So if the total urea nitrogen is 16 grams, then if we accept that 85% or 0.85 of total urinary nitrogen is equal to urea nitrogen, then we can formulate this equation. Total urinary nitrogen, which is necessary to understanding the full equation of nitrogen balance, is equal to urea nitrogen divided by 0.85. So it's a simple algebraic equation. So now you should understand why urea nitrogen is actually divided by 0.85. Indeed, this adjustment allows for a more accurate assessment of the complete amount of nitrogen in the urine, not just limited to the urea nitrogen. So now, in executing this particular equation on nitrogen balance, I propose that an individual who's consuming 135 grams of protein and whose urea nitrogen is 6 grams, the amount of nitrogen in the stool is 3 grams, and the amount of nitrogen found from sloughed off skin is 1.2 grams. The question then, is this patient in nitrogen balance? So what we're doing is essentially taking the 135 and dividing it by 6.25 to get the nitrogen equivalent. You remember that from the reasoning that I proposed to you in the earlier slide. So we're getting 21.6 grams of nitrogen. Now, the 6 grams of urea turns out to be 7.06 grams of total nitrogen in the urine. The 3 grams of stool as nitrogen stays 3 grams, and the 1.2 grams in the skin, from the sloughed off skin, stays 1.2. So what we do is we add the 7.06 to the 3, that's 10.06, to 1.2, that's 11.26 grams. So now we have the balance equation. 21.6 grams consumed minus 11.26 grams excreted leaves us with a positive 10.34 grams of nitrogen. What does plus 10.34 grams of nitrogen mean? Well, it means that the person is excreting less nitrogen than they are actually consuming. So this suggests that there is a protein accretion taking place, or deposits of protein in the body, usually coinciding with growth. And so this is actually a positive thing. So it means that the person now is in the process of depositing protein, creating tissue in their body. This would be something seen, for example, in the rehabilitation of patients that were malnourished. You could also see positive nitrogen balance in young children who are growing. They tend to retain more nitrogen than they actually excrete in order to favor growth. Now that I've finished covering nitrogen balance, I want to take a look at one very important aspect of protein quality, which we call biological value, or BV. This is nicely described in your chapter, so I encourage students to read this over, the aspect of biological value, so that you can get a firmer understanding after this lecture presentation. So now I want to define biological value in a sort of a general way. Biological value can be defined as the nitrogen utilized divided by the digestible nitrogen intake. What this basically means is the nitrogen utilized is the amount of nitrogen after digestion and absorption that is basically used in the biological system for the synthesis of protein. It does not refer to the amount of nitrogen that then is excreted in the urine. So we have to take that into consideration. Now, what do we mean by digestible nitrogen intake? Digestible refers to the nitrogen found in the protein that gets digested, right? The protein gets digested by the enzymes, the amino acids, and the dipeptides get absorbed into the enterocytes. And this is what we refer to the digestibility, the amount of nitrogen that gets absorbed, and it excludes the amount of nitrogen found in protein that gets excreted in fecal material. So a better representation then of biological value would be the following: the intake of nitrogen minus the bracket, then parentheses, of the fecal nitrogen minus the fecal nitrogen at time 0, that is before any intake, plus urinary nitrogen minus urinary nitrogen at time 0, that is before any nitrogen intake, and we divide this by 0.85 multiplied by 100. This gets divided by what we call the digestibility. The intake minus, that is the nitrogen intake, minus the fecal nitrogen, which is subtracted then by the fecal nitrogen at time 0 before the intake. Now these 0 measurements are necessary because even before the intake of actual nitrogen, there is residual nitrogen in the fecal material and in the urine resulting from bacteria. So I want to analyze this formula a little closer. First, I want to look at what is being subtracted from the intake of nitrogen, the I. The nitrogen that's found in fecal material and the nitrogen that is found also in the urine. So what are we actually measuring here? If we're extracting or excreting the nitrogen in the fecal material, it's that we're not using it. If we're excreting nitrogen in the urine, it is that we're not using it as well. There are two different types of utilization. First, let's get back to the F. What is being excreted in the fecal material is the nitrogen that was never absorbed, so not properly digested. If we're looking at nitrogen excreted in the urine, this is the nitrogen once absorbed into the system, circulating in our biological system through the vascular system. It's nitrogen that isn't utilized in the synthesis of protein, for example, and other secondary products. So it's not being utilized, it is then being excreted in the urine. So what we're left with then is the amount of nitrogen utilized in the system, because we are subtracting from the intake that which is not utilized metabolically and that which is actually excreted in fecal material. Now I want to look at the denominator, the intake minus the nitrogen found in fecal material minus the nitrogen at time 0 before actual any intake is occurring. So what is the I minus F naught? This refers to digestibility. So what we're getting here is the amount of nitrogen that actually is digested, or in other words, absorbed into the intestine or into the enterocyte, I should say. So of the nitrogen then that is ingested into the enterocyte, that has gone through digestion, and that involves, basically excludes the amount of nitrogen excreted in fecal material, we have what we have here in the I minus F minus FO, the amount of nitrogen absorbed. Of the amount of nitrogen absorbed, how much then is being utilized? And this is what we're measuring on the numerator. We're looking at I minus F minus naught, which is the same as the denominator. But in addition, we're looking at the nitrogen found in the urine, and of course corrected here for 0.85 to get a better estimate of the total urinary nitrogen. And so we're getting here the biological value. So it's basically stated of the nitrogen that did get digested and absorbed, how much of that are we utilizing? And of course the correction here is, of course, the amount of nitrogen excreted in the urine. So we're getting rid of that to look at how much is being utilized. And this is expressed, of course, as a percentage. Now I'd like to look at the two types of protein deficiency and look at their specific physiological distinct manifestations. There are two types of protein malnutrition. The first is called kwashiorkor. This is known as protein malnutrition. The second is called marasmus, and this is protein energy malnutrition. Children that suffer from kwashiorkor are essentially represented with the large edematous belly. So this is where an accumulation of water has taken place. It's called ascites in the peritoneal cavity, and so it causes this sort of bulging of the abdomen with water. Now we also notice that the limbs of these children are not really emaciated, although they may be slim somewhat. Kwashiorkor is basically a term from the Ghana nation that refers to the disease that the breastfed child gets after the birth of the second child. So the second child is born and displaces the first child off of the breast and then starts to rely on the local foods. And in cases of famine or economic difficulty, what has traditionally occurred is that first child that was on the breast, once displaced, will start eating something like the cassava, which is a very kind of primarily carbohydrate type of plant, but with virtually no protein. So they go from a rich source of protein, as in the breast milk, and they start consuming a plant base that has no protein. And so consequently, they get calories, but they don't actually get enough of the protein. Now let's examine why the belly occurs in these infants. And it's primarily because the blood proteins become significantly impoverished. And one thing we understand about blood proteins is their capacity to retain water within the vascular system. So when the proteins become impoverished, that is to say that there are less of them, then they have less of an osmotic draw, holding less water into the vascular system. And consequently, with the pressure of the vascular system, water leaks out into the adjoining tissues and ultimately into the peritoneum, thus causing a bulging of the stomach resulting from water accumulation. And this is really a direct result of protein malnutrition. Now, marasmus, by contrast, is extreme emaciation. So we don't really see water accumulation here because essentially a lot of the fabric of the vascular and of the anatomy of the individual, the fat and proteins, are essentially eroded or gone. So we get a tremendous loss of weight, and we get a tremendous loss of the different fat and protein reserves in the body. Notably, in this child, we see it as a form of cachexia, or extreme emaciation. So this is what we call a calorie and protein deficiency. In our hospital systems, we see really a lot of emaciation or cachexia among cancer patients that are significantly affected by this erosion of fat and lean tissue. And so we call this protein energy malnutrition in hospitals, or PEM, but it really is a combination of marasmus and oftentimes also kwashiorkor. So we'll see some of these patients that are extremely emaciated have the protruding belly, or ascites, quite pronounced in many cases.